we'll go ahead and welcome everyone to our Introduction to International HSCT, or Hematopoietic Stem Cell Transplant. We are so grateful to support individuals around the world. To learn more about two of the most frequented HSCT clinics, our executive team, Dave, Carey, and Julie Eberhardt are glad to accompany us to be featuring this panel, and we're so glad that everyone has joined us. Today we're going to connect you with a doctor and patient perspective about the clinics in Moscow and in Mexico, and help address some of the most commonly asked questions regarding these international options. We encourage you to engage with us in that Q&A. Actually, let's do that right now. So why don't we practice, and if you locate the Q&A box by hovering either at the top of your screen or the bottom of your screen, you'll see a gray toolbar and a double bubble that says Q&A. So you can use that to share your response to the question, why was it important for you to be here today? So if you share your response, that would be wonderful. That can help us gain perspective of what you're trying to gain by being here in attendance. And I'm even more grateful to our good friend Sara Leah Miller, who will be fearlessly guiding us through as moderator. And this agenda should give you a good idea of what to expect tonight. And so we'll provide you with an overview of those two most frequented international clinics in Moscow, Russia, as well as Puebla and Monterrey, Mexico. Representing Moscow, Russia, we hope and expect Dr. Fedorenko to join us. It's 3 o'clock in the morning there, so hopefully he will be able to join us. Accompanying him is Brooke, who was treated in Moscow in actually 2013, but we're grateful to have her perspective as a patient treated in Russia. Joined by them are Dr. Ruiz, as well as Dr. Gomez, as well as Jan-Marie Morgan, who was recently treated in June of 2020. So she's very new, being home from transplant, and we're grateful that she's joining us to offer her perspective. So initially, we will begin with some pre-recorded presentations highlighting features from both clinics. And during that time, we ask that you pay attention, but certainly use that Q&A box to pose any questions you have remaining that the videos don't answer. And then we'll do the work behind the scenes to compile those questions and pose the questions to our panel. And hopefully we'll address as much of them as we can. Thanks again for participating.
Good evening. Hello, dear friends. How are you? I am okay, thank you, and I hope you are well. So I am very happy to take part in this event to share our experience, our approaches of transplantation in multiple sclerosis patients. When we treat multiple sclerosis, there are two main questions. Can we cure it? And can we prevent disability? And the answer is it's possible and it's impossible. So it's impossible to cure multiple sclerosis, and it's impossible to prevent disability if we use traditional treatment. Why it's impossible? Everybody knows that all disease-modifying drugs are not able to eliminate autoreactive T and B lymphocytes clones. This is a simple answer why standard treatment is limited to stop multiple sclerosis. You may ask me, what means effective multiple sclerosis treatment? And the answer is, firstly, to stop MS progression for long period, I mean years. And second, to prevent irreversible CNS damage and critical disability of patient. And third aim is to improve significantly neurological deficit for long period, years. What doesn't meet non-effective treatment? We can meet it every day, every month when we have disease-modifying drugs. To decrease the rate of inflammation, it's not so important for patients because patients can have inflammation, can be disabled without inflammation. So this is only medical position, but not patient-related outcome. To decrease the number or size of lesions in CNS. In case of disability, it's not so important how many patients you have, how many lesions you have. It's possible to have one lesion and be in wheelchair, and to have 100 lesions and run crosses and marathons. So it's also as a position of non-effective treatment. To decrease the number of relapses per year and other surrogate goals of treatment. All these treatment goals are important if we use disease-modifying drug and can be a result of non-effective treatment. When we treat multiple sclerosis, we need to follow very significant aims to stop MS, to improve quality of life, to prevent disability. There are three main goals. Principally, new approach is needed to treat multiple sclerosis. And this approach is based on high-dose immunosuppressive therapy and autologous hematopoietic stem cell transplantation. Transplantation is a new and promising treatment strategy in multiple sclerosis. It's about 1,500 to 2,000 transplantations all over the world has been provided. It's important to know that transplantation-related mortality is about 3 to 8% for myeloablative protocol. This is why it's so important to use less intensive conditioning regimens, and using these protocols is supported by idea that transplantation isn't only an immunosuppressive therapy, but also could have an immunomodulatory component, and low-intensity lymphoablative protocol can be associated with similar outcome results, but presented less toxicity to compare with myeloablative protocols. And the main idea of using transplantation in multiple sclerosis is to find the best balance between toxicity and safety, and to improve long-term outcomes of multiple sclerosis treatment. The core target of transplantation is autoreactive T and B lymphocytes clones. Transplantation affects autoimmune cells, T and B lymphocytes clones, and allows to eradicate all autoreactive T and B lymphocytes clones. So, if we want to provide effective treatment, we should increase summary dose, and we should decrease intervals between courses. This is the principle of conditioning chemotherapy: dose intensification and dose density. Another very important position is theory of therapeutic corridor. The most important thing is to find the best balance of toxicity and effectiveness. And lymphoablative transplantation is inside of zone with the best balance between effectiveness and toxicity. If we increase protocol dose, we go to zone of high toxicity, which is dangerous. If we decrease dose, we go to zone of low effectiveness, closer to disease-modifying treatment. So we should carefully assess risk and benefits and to provide the optimal protocol with the best balance of effectiveness and toxicity. This is 2 minutes video about National Medical Surgical Center and our hematological department. First step is careful examination according to international rules. We provide comprehensive blood test, urine test, X-ray, ultrasound, MRI with contrast, and other functional tests according to modern international rules. After finishing examination, we analyze all results and make decisions about risk and benefits of transplantation. The second stage is preparation, stem cell stimulation and collection. You can see working of stem cell apheresis machine. It takes 1 or 2 days for apheresis. We store stem cells in cryobank during chemotherapy, which is the next stage of treatment. Chemotherapy is one of the most important stages of this treatment. Chemotherapy allows to eliminate wrong immune system as a reason of the disease. We use modern approaches of protection body organs from chemotherapy-related toxicity. Also, we use modern techniques to provide the best control for chemotherapy-related symptoms, like nausea and vomiting. And after chemotherapy, we reinfuse stem cells back. It's a great event for our friends. It's a kind of second birthday, stem cell birthday. And dear friends, I tell you some words about our principles of transplantation, and our approach for transplantation in our hospital. And I would like to tell you some words about our summary and results. Transplantation is new and promising therapy for multiple sclerosis with history of about almost 20 years of using it. Early transplantation for patients with low disability in early stage of multiple sclerosis is the best approach. Early transplantation, according to our results, demonstrates potential to stop the disease progression and to prevent disability formation in 92% of patients. So this is why this is the most promising treatment strategy in multiple sclerosis. I don't know another approaches with similar results. The favorable factors for transplantation in multiple sclerosis, according to our results, are early transplantation. It means a DSS score less than 3.5. Younger age, disease duration less than 5 years, relapsing remitting variant of multiple sclerosis. Other important things like presence of active lesions, gender, ATG, and quality of life before transplantation are not so important and do not influence on event-free survival, or other words, on the result of transplantation. Transplantation can be used for primary progressive and secondary progressive variant of multiple sclerosis with a little bit lower success rate. But this treatment is also effective for primary progressive and secondary progressive variants of multiple sclerosis. The vast majority of adverse events as a result of transplantation last for a short period of time and can be well controlled. Long-term side effects should be observed and analyzed carefully in all transplantation departments. According to our results, transplantation was accompanied by a significant improvement in patients' quality of life and symptoms, with statistically significant changes in the majority of PRO patient-reported outcome parameters. And some words about our hospital. National Medical Surgical Center, named after Pirogov, and Department of Hematology and Cellular Therapy, named after Maximov, was created in 2003. Transplantation department was created in 2005, and the first transplantation for multiple sclerosis was provided in 2005. So we have almost 15 years of experience in this area. Since then, more than 2,500 transplantations for hematological malignancies and autoimmune diseases have been performed. Professor Andrei Novik was the first chief of the department and the pioneer of this approach in Russia. He developed Department of Hematology and Cellular Therapy in 2005. November 2019, we organized the big international conference, Stem Cell Transplantation for Treatment of Autoimmune Disease. It was first and great event in our hospital in Russia. 19 speakers from 9 countries discussed the main topics of using transplantation for multiple sclerosis and other autoimmune diseases. This is the speakers map. More than 19 world-known professors from Europe and the USA. We discussed the main topics of using transplantation in multiple sclerosis and in other autoimmune disease. Such famous doctors as Joachim Biermann, Tobias Alexander, Richard Bird, John Snowden discussed main topics, and we received the high assessment of our research and our clinical practice. So, dear friends, I am very thankful that I have opportunity to share our experience to improve results of treatment of patients with multiple sclerosis, and I am very happy to introduce our department and our approaches. So, thank you very much for your attention. Thank you very much for taking part in our webinar, and I wish all my colleagues the best practice and all MS sufferers to fight the disease in the best way. Good luck.
And so now we will hear from Clinical Ruiz.
Hi, my name is Guillermo Ruiz. I am one of the 4 physicians in charge of the HSCT program in Mexico. As you know, it's myself, Dr. Gomez Almaguer, Dr. Ruiz Delgado, and Dr. Gomez de Leon. On behalf of HSCT Mexico, we thank HSCT Warriors for the invitation to share with all of you our experience and our data. These are the salient features of our program of HSCT for multiple sclerosis in Mexico. We use laboratory risk for all the laboratory workup. Pharmacentro provides medication. Blood bank is in charge of apheresis, transfusions, and so on. Dr. Gomez Almaguer and myself conduct the HSCT and are in charge of consultations, visits, and also supervise the nurses. We also employ a surgeon and an anesthesiologist for the placement of the catheter. We use also a hospital for ambulatory procedure for catheter placing, chemotherapy, spirometry, electrocardiogram, consultation with a cardiologist, neurologist, transportation, driver and translator, lodging for patient and carrier, food for patient and carrier, and we calculate that the number of employees involved in our program is around 500. The space that we have devoted for the HSCT program is around 8,000 square meters. Patients remain in our premises for 28 days, and there are 2 campuses, one in Puebla and one in Monterrey for our program. Some of the salient features of the campus in Puebla, the medical offices, the rooms to see the patients, the apheresis room, and also the chemotherapy room. Additional pictures of our facilities. We have meeting rooms, the waiting room, consulting room, and also we have a garden for the carers during the procedure. We also have a lodging for the patients. These are some features. Every apartment has 2 rooms, one for the carer and one for the patient. And we even have a roof garden to take some sun, since most of the patients came from cold places. Medical facilities in Monterrey, the chemo room, meeting room. This is also the chemotherapy room. And also the lodging facilities in Monterrey, as you can see, they're very well displayed. This is Dr. Gomez Almaguer and myself, and additional pictures of the lodging facilities in Monterrey. Transportation is also considered. It is adapted for wheelchairs. We transport from and to airports in Mexico and Monterrey, transport the patient from the lodging to the clinic, and city transportation is provided if needed. Very recently, we started a collaborative program with the National Institute of Neurology and Neurosurgery, and they are now, this is a government institution, and they are now sending patients to be treated at clinical risk. These are the first two patients that we grafted, both of them with HSCT, and we are proud to be part now of the places in which the government can send selected patients. In addition to grafting patients, both Dr. Gomez Almaguer and myself are very interested in participating in academic activities. We have gone to very many meetings to present our data. Some of them have been presented as posters, and some of them have been presented as oral presentations. We are a private HSCT treatment center, and both Dr. Gomez Almaguer and myself have conducted more than 3,000 HSCT procedures during more than 20 years for hematological and autoimmune conditions. Our renowned team of experts provides personalized, comprehensive care that helps patients manage their symptoms and maximize their quality of life at all stages in their condition. Salient features of the curriculum vitae of both Professor Gomez Almaguer and myself. I was trained in San Luis Potosí, and later on, I spent some time at the Mayo Clinic in Rochester. And I was elected a distinguished alumnus of the Mayo Clinic and also master of the American College of Physicians, and probably this honorary degree, Doctor Honoris Causa by the University Autónoma de San Luis Potosí, is one of the salient achievements in my academic career. Professor Gomez Almaguer was trained in Monterrey. He also trained in the same hospital as I trained in Mexico City. He's currently the head of the hematology service at the University Hospital in Monterrey, and currently the chair of council of the International Society of Hematology. We have been involved in very many papers, as well as Dr. Ruiz Delgado. He was a postdoctoral fellow at the Mayo Clinic. He is currently the Deputy Director of Research and Education in Clínica Ruiz, and also in Centro de Hematología y Medicina Interna. And he is a member of several societies, such as the American Society of Hematology, International Society of Hematology, and so on. He has also an extensive activity of paper publishing, as well as Dr. Andrés Gómez de León. He was trained in Hospital de Nutrición in Mexico City, and later on in Hospital Universitario Dr. José Eleuterio González in Monterrey, Mexico. These are the salient features of our HSCT method. We conduct the transplant on an outpatient setting. This avoids hospitalization and reduces substantially the risk of nosocomial infections. This is an outpatient treatment that helps also to avoid COVID-19. We use the 4 doses in 2 blocks apart of the chemotherapy, specifically of cyclophosphamide. This results in a reduced renal damage, reduced bone marrow damage, and reaches the same level of immunosuppression. We employ non-cryopreserved cells. We never freeze the cells. This results in improved viability, reduces manipulation, and reduces contamination. Our procedure is very safe. We have had 2 fatalities in 951 patients. And we have treated since the pandemic in February 2020, 102 patients we have grafted. We were able to detect COVID-19 in 2 out of these 100 patients, and we had to cancel the transplant and to postpone it until the infection is clear. We have successfully transplanted in the COVID-19 era 100 patients with hematopoietic stem cell transplantation. We are not required to have the SARS-CoV-2 PCR test done prior to coming to our premises. And every patient and caregiver will be tested upon their arrival into our facilities. Most patients can be grafted with only one apheresis procedure, 90%. Most complications are handled as outpatients. The chances of going to the hospital using our method is around 4%. There is a very low transfusion requirement. 10% of patients require red blood cells or platelets. And we have shown that practically all type of multiple sclerosis, even the progressive forms of multiple sclerosis, respond to our HSCT. I will elaborate more about this particular point later on. We accept patients with an EDSS score up to 8 points. And as I said, we use cyclophosphamide in 2 different blocks apart, and we employ higher doses that we're talking about as compared to other protocols conducted in other parts of the world. There is no visa requirement to come to Mexico, and we also include low doses of steroids. This figure here depicts the transplant that we started doing in 1993 and up to 2020. This is in clinical Ruiz. Most transplants are autologous, and we have also conducted allogeneic transplant. We are currently the largest center doing transplants in the country, including the governmental institutions. The indications of allogeneic transplant are mainly acute leukemia, whereas the main indication of autologous transplant is multiple sclerosis. The female to male ratio is 2 to 1, as in most series of patients with multiple sclerosis. And this is the place of origin of the patient that we have grafted. Most patients, 44%, have come from the United States, 23% from the United Kingdom. We have also patients from Norway, Canada, Australia, and some others. And our current figure is 951 patients, which represents 100%. This is the places for the patients have come from: the United States, Alaska, which is part of the United States, and the United Kingdom, also Canada, and some other parts of the world. In addition to conducting the transplant, we have been interested in presenting our data worldwide. We presented our data in meetings of the International Society of Hematology, American Society of Hematology, the bone marrow transplantation tandem meetings, American Society of Hematology several times, as well as tandem meetings, and now this American Society of Bone Marrow Transplantation has changed the name, and now the name of the meeting is Transplantation and Cellular Therapy Meeting. Our most recent presentation was done in Florida in February this year, prior to the pandemic. This is the poster that we presented in the meeting of the American Society of Hematology December 2019. And I will elaborate a little more about the result, but we presented the data in this particular paper of 739 patients. Our numbers are now 951, as I already showed you. We have been interested in doing publications. This is an initial publication, which is a feasibility study. The question here is, can this be done on outpatient patients using non-cardiac reserve cells? The answer is yes. This paper deals with the renal damage in patients with multiple sclerosis and indicates that by splitting the doses of cyclophosphamide, we are able to damage less the kidneys of the patient with the disease. This editorial here refers to the usefulness of the current treatments of multiple sclerosis. Drugs produce a response of at most in 50% of patients, whereas most transplant programs are around 80% response. This indicates that nowadays, the best therapeutic option for patients with multiple sclerosis is hematopoietic stem cell transplantation. This other paper, January 2019, analyzes the safety of the procedure conducted on an outpatient basis and employing non-frozen graft in persons with multiple sclerosis. The conclusion of that paper is, yes, the procedure is safe, and in our hands, only 2 fatalities out of 951 patients have been shown. This paper, published this year, some months ago, deals with the changes in the expanded disability status scale score in patients with multiple sclerosis. This analyzes 617 consecutive patients with multiple sclerosis autografted in our center, and I will show you some of the results of the response to the treatment as far as the neurological condition is concerned. 951 patients, we have hospitalized 40 of them, only 2 have had fatalities, and as you can see, the efficacy, which is defined by the addition of improved conditions to stabilized conditions, are around 80% a long time. You can see that all type of multiple sclerosis do have some response. The better responses being observed in relapsing remitting. This is the changes at 12 months of patients with relapsing remitting multiple sclerosis. This line here depicts patients who stabilize the condition, and these patients are those that drop the EDSS score up to 6 points. So adding stabilization to response, we get an 85% response rate for patients with relapsing remitting multiple sclerosis. In primary progressive multiple sclerosis, 25% of patients do not respond, and the response rate is 75%. Whereas in secondary progressive multiple sclerosis, the response rate is around 79%. Again, as time goes by from 12 to 18 months, the response rate is improved. This is the green bars here are the patients that do respond, and the response rate from 75% to 83% in primary progressive, secondary progressive, and also relapsing remitting multiple sclerosis. So this indicates that less than 20% of patients do not have a response to our procedure. As a result of the changes that we have done to the stem cell transplantation procedures, the Center for International Blood and Marrow Transplant Research granted us, both David Gomez-Almaguer and myself, this distinguished service award. It was delivered by Dr. Paul Martin, who was by then the president of the Center for International Blood and Marrow Transplant Research. Very recently, some months ago, we organized in Puebla Hematopoietic Stem Cell Transplantation Forum, and we had a chance to have here Professor Gomez-Almaguer from our program, Dr. Richard Burt, who is very well known for his contributions to the HSCT programs in multiple sclerosis. I also had a chance to have some lectures, and it was an interesting experience in which Dr. Gomez-Almaguer, Professor Burt, and myself had a chance to interchange some ideas. Now, we are aware of the fact that there are some other HSCT facilities in the world, in the United States, Germany, Sweden, Russia, United Kingdom, Malaysia, Italy, Singapore, Belgium, Brazil, Israel, India, and Spain. And we congratulate every center for offering the best treatment option for multiple sclerosis up to now. And we also recognize the fact that there may be differences in the protocol, but we all have the same goal, which is helping patients. Now, this is the last presentation, the last slide of my presentation. And I am proud to be part of this effort to help patients with multiple sclerosis in our facility. Thank you for your attention.
Big thank you to both doctors for presenting such comprehensive overviews of their clinics. And at this point, I want to pass the microphone to Sara Leah Miller, our amazing moderator, who will introduce our panelists and take the floor and host the rest of the conversation. Thanks to everyone for being here.
Hello, everyone. My name is Sara Leah Miller. I am an HSCT hopeful. That's what Jen calls me. And I'm really glad to be a part of this. We are honored to feature world-renowned physicians and patients on our panel tonight. Is Dr. Fedorenko here yet, or has he joined? No? Okay. Well, I'm still going to give you a short bio on him. Dr. Denis Fedorenko, MD, PhD, and Associate Professor at Pirogov's National Medical Surgical Center, Department of Hematology and Cellular Therapy, named after A. Maximoff. Dr. Fedorenko graduated from Medical Military Academy in 1989 and completed postgraduate studies in 2004 in the Department of Hematology and Clinical Immunology. Medical Military Academy. He earned his PhD in 2016 with a focus in comprehensive outcome assessment of HSCT effectiveness in lymphoma and multiple sclerosis patients. He's a member of the American Society of Hematology, the European Hematology Association, and coordinator of the program, is it autologous? Is that right? HSCT in multiple sclerosis and other autoimmune diseases, and co-author of more than 200 publications and one patent. Dr. Guillermo Ruiz Arguez is director of the Center for Hematology and Internal Medicine in Puebla at Clínica Ruiz, director of Teaching and Research Division Laboratorios Clínicos de Puebla, Clínica Ruiz, and professor of hematology. He completed his degree in internal medicine in 1980 and hematology in 1982. And completed postdoctoral research in hematology at the Mayo Clinic in Rochester, Minnesota in 1983. As noted in his presentation, Dr. Ruiz has received countless honors and awards, including the Mayo Clinic Distinguished Alumnus Award in 2011, and has authored 787 papers in international journals and 81 chapters in books. We're also honored to feature these esteemed physicians and pleased to welcome two of their patients to offer perspective of their experience at each clinic. Brooke Slick, hi Brooke.
Hello.
Is a host of the MS Gym podcast, an excellent podcast, a blogger and longtime HSCT advocate from Central Pennsylvania in the United States. She received HSCT in Moscow in 2013 and was diagnosed with relapsing remitting MS in 2006. And Jan Marie Morgan, hello.
Hello.
Is a nurse practitioner and wound care specialist from Burlington, Ontario, Canada, and underwent HSCT in Monterrey, Mexico in June 2020. She has relapsing remitting MS and was diagnosed in 2016. Hello, everyone. Thanks for being here with us.
Hi.
So we have a list of some questions that people have sent ahead of time, and we also will go through the Q&A. Do not be afraid to still ask questions within that forum. Again, as Jen said, it's at the very bottom of, hopefully in the very bottom of your screen, there's a Q&A with a double box. And you can click on that and add your question. So first of all, I just wanted to go through a little bit about both facilities. One of the questions was, well, I'll just put these kind of together. They wanted to know how much does it cost to get HSCT at each facility, and how long does it take to get approved, and is there a waiting list for your facilities at this time? Dr. Ruiz, since you are here, would you like to talk about this a bit?
Well, one of the reasons we have two facilities in our program at Clínica Ruiz is to shorten the waiting time period for patients with multiple sclerosis. So we are grafting patients with MS both at Monterrey and also in Mexico. The method is exactly the same, in Puebla, I'm sorry. The method is exactly the same, and the venues may change a little bit since there are two different cities. The calculated cost of a procedure in either of our two facilities is $54,000, right?
Okay. Is there a waiting list at this time, or I know that you talked about the fact.
We have a delay to respond applications with patients with multiple sclerosis of around 7 days.
Okay.
We start a group of patients every 28 days. So it's about every month. So that means that we do have around 12 group of patients each year, including our two facilities.
What would disqualify someone from HSCT? Are there qualifying criteria? Do you need to have active lesions to go through HSCT?
No, we do not require active lesions to be present in the studies of patients with multiple sclerosis. We can graft patients with an EDSS score up to 8.
Okay.
And we graft all type of patients with every type of multiple sclerosis.
What diseases other than MS does your facility use to HSCT to treat?
Well, we have, our program includes ankylosing spondylitis, Sjögren syndrome, uveitis, scleroderma, systemic lupus erythematosus, vasculitis, and other subtypes, and type 1 diabetes, provided the diagnosis has been done 3 months before the transplant. As far as the hematological indications for our transplantation program, our main indication is acute leukemia, multiple myeloma, lymphoma, aplastic anemia, and myelodysplasias.
Let's see. What is the most important thing that a person would need to know to be physically prepared to come to your clinic?
Well, since we require patients coming to our country and to our facilities, we ask them to have an ADSS score below 8. So that means that they can transfer from a bed to a chair by themselves. We encourage all patients to travel to our premises with an accompanying person, but that is not strictly necessary because we can provide an accompanying person if necessary.
Is a caregiver required when they come, when the patient comes to your clinic, or is it encouraged?
It is desirable, but it is not strictly necessary. If a patient does not have a caregiver, we can provide one.
Does your facility provide any travel or lodging assistance?
Yes. All patients are lodged in a special building that we have for this purpose. Every suite has 2 bedrooms, one for the patient and one for the accompanying person. All of them are also provided with food, which is supervised by the physicians of the program.
Let's see. Do you believe that performing the procedure outpatient is preferable to inpatient? I saw that you talked a little bit about the advantages of doing that way during COVID-19. So I'm guessing yes, but would you like to speak on that a little bit?
Yes, I am totally convinced that doing transplants on outpatient patients is substantially better than doing them in hospitals. We started doing research in this particular area around 25 years ago, dealing mainly with patients with hematological malignancies. And we were able to show that patients grafted outside the hospital did substantially better than those grafted in the hospitals. Having gained expertise on that particular point, we then apply this knowledge to the transplants of patients with multiple sclerosis. And as I said, we have shown that the chances of having a complication outside the hospital are substantially lower. The risk of nosocomial infection is considerably decreased. And in what is happening right now, the COVID-19 pandemic, we can very easily handle all these people having contact with the patients by keeping them in a controlled environment outside the hospital. So I strongly feel that doing the transplants, not only for multiple sclerosis, but for all types of diseases, is substantially better. I have also to say that as a result of our showing to the medical community that transplanting was possible on an outpatient basis, was one of the main reasons why we were granted this Distinguished Service Award. Now a lot of people in the United States is grafting patients on an outpatient basis. 20 years ago, this was not even considered.
Let's see. Talking to, let's see, sorry. Can we talk a little bit about the process? So we had a question about what benefits you receive from not freezing the stem cells and how do you store them instead?
Well, yes, in order to make a transplant, you have to use hematopoietic stem cells that have been pulled out of the patient by a pheresis procedure. So if you freeze the cells and then you thaw the cells, you lose around 60 to 70% of the cells just by freezing and thawing the cells. We have also shown in previous papers that no freezing is substantially better than freezing cells in cases in which the period of time in which the cells are kept outside the patient are shorter than 5 days. So we can keep the cells in a conventional blood bank refrigerator without freezing them for up to 5 days. In the case of the transplant of patients with multiple sclerosis, the cells are kept outside the body of the patient only for 48 hours, and we have measured the viability of the cells, which is always above 95%. So not freezing the cells is, number one, cheaper, number two, safer, number three, it allows more rapid engraftment, and number four, it decreases substantially the possibilities of an infection by manipulating the cells outside the body.
They were asking about the why myeloablative is better than non-myeloablative protocol.
No, that's not true. Nobody has shown that myeloablative is better than non-myeloablative. Most studies have shown that they are about the same. What is different is the toxicity. The chances of having a complication using a myeloablative protocol are substantially higher than those using non-myeloablative protocols. So up to now, the results are about the same, and the difference relies mainly on the toxicity of the programs. Something happened with Sara.
It looks like Sarah's video got a little frozen.
Yeah.
We gotta love technology. Well, and so maybe I'll invite Jean Marie to speak of your patient experience.
Oh, hello. I'm Dr. Denis Fedorenko.
And here comes Dr. Fedorenko.
Oh, good. Well, go back to him. You don't need to hear from me.
Welcome, welcome.
Thank you very much. Are you okay?
Sure thing. Turn up your audio a little bit and we can hear you.
Okay.
Wonderful. Thanks so much for joining us. We were just talking through some patient questions, and Dr. Ruiz was just explaining that the majority opinion is that non-myeloablative HSCT is less toxic and therefore preferred or safer. than myeloablative.
Thank you very much, and thank you very much for your support of transplantation activity and for joining me to your conference webinar. As for myeloablative and non-myeloablative, the idea of non-myeloablative is that non-myeloablative program isn't only immunosuppression, but also immunomodulation. And first clinical trials, like clinical trials in South America, in Brazil, in the USA, found that effectiveness on myelo and non-myelo is the same, but toxicity and side effects are much more common for myeloablative regimen. And if we treat chronic disease like multiple sclerosis, when person with MS, as you know, lives long life as normally. And our main aim of treatment is to improve quality of life and to prevent disease progression. So we need to think about mainly quality of life because it's not fatal disease like cancer or leukemia. So we should think about secondary autoimmune diseases, which are quite common in myeloablative protocol, and secondary malignancies, which is quite dangerous. Of course, we should think about transplantation-related mortality. So on the other side, effectiveness is the same.
Thank you for clarifying that. Another question that came up earlier was about the wait times to get into Russia if you're currently treating patients and the cost factor.
You mean chemotherapy for stem cell collection?
No, for HSCT.
We don't use...
So if there's a wait time for patients who apply, how long does it take between application and then...
Usually now it's a little bit, I think it's temporary difficult time because of closed wards and difficult communication between countries. But I think it will be much better in future. Usually our waiting list is about 6 to 12 months. We try, but the decision about admission is based on firstly medical situation. If patient has very difficult situation like very aggressive disease and urgent situation, we try to provide admission as soon as possible. Now, unfortunately, some boards are closed and because of COVID time, and we need to, we have some difficulties with admission, but we have free spots for November this year and for the beginning of next year.
That's
but I hope both will be open after New Year because in Russia we have quite stable situation with COVID. Also, we have vaccine and modern medication. And I think it will be better. And what's about cost? The cost is around 45,000 euros.
Okay.
45,000 euros, yes.
Euros. Yeah.
This cost includes all examination, accommodation, and treatment.
Very helpful. Thank you. I'm glad you made it on.
Yeah, welcome.
Okay, so Dr. Ruiz was just, sure. Dr. Ruiz was also just explaining that in their protocol, they do not freeze the stem cells or cryo-freeze them, that they use refrigeration for up to 5 days, and that that's a foundation of their protocol. And so people are curious as to why that might be different in Russia and why you freeze the cells.
Okay, we follow international rules like European and American. And actually, according all international standards, we should store stem cells in liquid nitrogen if we have waiting period from collection to stem cell refusion more than 2 days, because each day we usually lose about 5 to 10% of stem cells. So it's kind of rules. We use chemotherapy during 4 days, like in Chicago. So we use 200 milligram per kilogram body weight for 4 days. If we use 1 or 2 days, like for multiple myeloma, we can keep these cells in normal fridge, but we use longer chemotherapy, and we need to store these cells more than 5 days, 6 or 7. So it's too long. Also, modern approaches of cleaning stem cells from liquid nitrogen provide quite safe transplantation. Now we don't have any side effects of cryopreservation, and we consider that we can save more cells.
Thank you.
All centers around the world provide deep freezing if they have chemotherapy more than 2 days. So this is only different approaches.
Sure, right. And I think both presentations point out that every facility has its own protocol. And it's so helpful to have you both here to clarify. Ultimately, the goal of both is to help progression, right? So how about we hear, sure, how about we hear a little bit from the patient perspective? I would love to introduce Brooke Slick, who traveled to Moscow, Russia in 2013. And your episode and your follow-up interview on the podcast just aired today. So I appreciate you participating in that and sharing your journey with HSCT and helping others understand what it's like. And that's my question for you. What was it like to travel to Russia to receive this significant medical procedure?
I looked at it as, and I've said this, I've used, hello, Dr. Fedorenko. I missed you very much.
Hello,
and I missed the staff as well. Nice to see you.
Me too. Nice to see you.
I always use the analogy that I felt like I had won the lottery and that I was on the plane, you know, hidden in my luggage was this ticket that I was going to cash in once I got to Moscow, that I was going there to pick up my prize. I know that seems a little strange, but I seriously wasn't even that scared. And the reason that I wasn't that scared about the treatment itself was because I knew where my disease was going. And when you have MS, people who have MS, they know. You know when you're declining, and you know when things, you know, start to snowball and you're like, wow, I got to slow this down or I'm going to be in big trouble here. And that's where I was at the time. So for me, traveling to a foreign country where I don't speak the language and staying in a hospital for a month, none of that was as scary as the prospect of what was awaiting me with MS if I did not have the treatment. And of course, I had already been through, you know, beta-seron and Avonex and Tysabri and Galenia and Solumedrol and, you know, if you have MS, you know the drill. So I knew, plus I just knew in my heart of hearts that this was the right decision. So I really didn't have any fear about the treatment overall. Of course, we all have our individual fears about, you know, having your cath line put in and the chemo, and, you know, we all have those fears to some degree. And 9 times out of 10, you get there and you're like, wow, you know, that cath line was nothing. And even if it was something for you, it doesn't last long. And then it's done. And, you know, when you get home, you look back on it and you think, gosh, why was I even afraid of that? So again,
which is why it's so helpful, yeah, for you to share your perspective and all of your experience in the past 8 years post-transplant, and then
almost 8. Gosh.
Almost 8. And here we have Anne-Marie, who's freshly home. You were transplanted as one of the first groups in the world of COVID, right? So you were transplanted in June of 2020, and of course, her screen is frozen now because we love technology.
Yay.
I bet I sent you Jan Marie's link, and so I think that's part of the issue. But anyway, we're glad to have you back, Sara.
Well, thank you. There was some internet issues, but I don't know what I missed. So,
and so we were hearing from Brooke about her experience in Russia, and about to ask Jan Marie about her experience in Mexico as being one of the first in the cohort treated post-COVID. And Dr. Ruiz, you might be able to confirm this, but basically she mentioned in her podcast interview that all fears were alleviated because of the extra precautions that you all take, and being in the campus and in that dormitory where she's like, it's just her and the cleaning person coming every day to sanitize everything, that really helped to ease her concerns. Is there anything else you all are doing in the world of COVID to elevate that safety?
Yes, we have grafted during the pandemic 104 patients with HSCT after following our stringent protocol. We do not need the patient to have a COVID-19 test negative prior to coming to our premises, because we run a test to all the persons that are entering our premises, both patients and carers. All of these patients have been grafted successfully. Nobody has been infected, and we think that we have developed a method to do this safely. The details of this method could be the topic of another webinar, but in our hands, handling all this situation has been possible. And as I said, we have been able to graft during the COVID-19 era 104 patients with multiple sclerosis with no problem at all and no complications at all. Not only that, we have also asked the patients that we have grafted previous to the pandemic if they had had COVID-19. And out of around 700 patients, we got a response letting us know that 4 of them had COVID-19. COVID-19 was not very bad in these patients that had been previously grafted, and they could be treated at home. No one of them needed to go to the hospital. So we feel that it is possible to transplant multiple sclerosis patients in this pandemic era, having special cautions. All this information has been recently published. Our method to conduct this procedure in the COVID-19 era has just been published in Hematology, a British journal, and we were able to show that this is possible, provided you have a lot of extra cautions.
Dr. Fedorenko, there were several questions that were posed about the cost of the program, and also if you suggest having a caregiver during your treatment there.
Okay, you mean cost our program in Moscow, yes?
Yes.
The cost of transplantation in Moscow is the same as previously, not high in this COVID time. It's about 45,000 euros.
Okay.
It includes all steps: examination, including MRI and full body examination, treatment, and accommodation. So it covers all.
Okay.
And of course, I absolutely agree. Okay.
Yeah, that they should bring a caregiver.
With Dr. Ruiz, the transplantation is safe and possible in COVID time if you follow special precautions and rules. For example, we check patients for COVID in the beginning, at admission, after coming to hospital. So also we ask patients to have COVID test before coming to hospital. And of course, we have strict regulations inside of our hospital to prevent infection during transplantation procedures. So I think transplantation is safe in hospital. Also, we didn't have any side effects and any difficult COVID situation after transplantation in our patients who had this treatment before pandemic, during pandemic, now also it's safe.
Does Moscow actually require a visa at this time?
Yes. Unfortunately, we have some closed boards, but I think this is temporary, and this is not because of situation in hospital. This is because closed boards, officially closed boards between countries. For example, we are opened with Great Britain, with Switzerland, with some other countries, but temporarily closed with other European countries. I think this is maybe mainly political situation than medical. But I hope everything will be better.
we all do, yeah. Jen, did you ask about the EDSS level of patients for Moscow?
No, I did not.
Dr. Fedorenko, what is?
Yeah. We, of course, transplantation should be provided as soon as possible, and the higher EDSS score, sometimes the more difficult recovery after transplantation, the more we need to repair, the more difficult rehabilitation. So our up level of EDSS is 6.5.
Okay.
Sometimes if patient has EDSS 7.5, but this is quite rapid progression during 3-6 months period, we can do it, of course. If disease is clinically stable during long period of time, like 1 year or more, and high EDSS score like 7.5 and higher, I think it's too late. And transplantation isn't too effective.
Brooke, what was your EDSS going to Russia?
You're muted.
We recommend to do it as a higher level 6.5.
My EDSS was between 5 and 6, depending on the day.
Subjective, right.
Depending on the day.
Welcome back, Jan Marie. We were
Sorry
trying
about that.
Oh,
But another,
go ahead, Dr. Fedorenko.
okay, another important thing, aggressive or malignant multiple sclerosis is indication in spite of high EDSS score if disease is very rapid and aggressive. So this is a kind of specific situation.
Is your facility, Dr. Fedorenko, inpatient? Like, do you have inpatient and outpatient, or is it mostly outpatient?
We have only inpatient treatment, and we use sterile rooms, like almost all other transplantation departments around in the world, because we are governmental center, we are traditional transplantation center and a kind of university hospital of Russia. So we have postgraduate students, we have research laboratories, and we provide transplantation as inpatient treatment.
Great.
Using special sterile rules with sterile air conditioning system, with sterile water. So we consider maybe for today it's safer, especially if we use protocol during 4 days, 200 for 4 days.
Jen, when we lost Jan Marie, you were about to ask her about some things. Would you like to go ahead?
Yeah, thank you. Well, just your experience being in Monterrey at Clínica Ruiz, and I think Dr. Ruiz, it is true that Clínica Ruiz is the only standalone facility to offer HSCT outside of a hospital setting. Is that right?
I don't know. I am aware of the fact that we are the institution that has been conducting allogeneic transplantation and autologous transplantation on an outpatient basis for very many years. The first group of researchers in the world to publish a paper about allogeneic bone marrow transplantation outside the hospital were Dr. Gomez Almaguer and myself. So having gained expertise doing allogeneic transplant and auto transplant for hematological malignancies, we moved into the autologous transplant setting for patients with HSCT, and it was rather easy for us to conduct the transplant on an outpatient basis for patients with multiple sclerosis. I have to tell you that when I was trained at the Mayo Clinic, nobody could dare in doing an autologous transplant for myeloma on an outpatient basis. Nowadays, 25 years after my stay at the Mayo, they are doing transplants for patients with multiple myeloma on an outpatient basis. And everybody has shown that the complications, the evolution of the patient, and so on are substantially better if you keep the patient outside the hospital than in the hospital. This is the reason why we are doing this on an outpatient basis. And as I said, we have probably nowadays the largest experience in the world doing transplants on an outpatient basis.
And so, yeah, Jan Marie, just tell us a little bit about your experience there.
So yeah, so I applied. I remember it was a Sunday in January, and by Thursday I had I was booked and ready to go to Monterey. So I chose Monterey because I have a very strict diet and I don't eat gluten and dairy and all that stuff. So I wanted to cook for myself. And I'm lucky, I have a husband who loves to cook. So I'm very lucky that way. So we chose Monterey. And I love what you said, Brooke, about thinking you won the lottery and going like you had a ticket in your bag. I think that's a great analogy. Everyone around us was so scared for us because of COVID, but we were just so excited and so happy to get there. And the protocols, I am a nurse practitioner. I've worked in the hospital for 30 years, and I tell you, this is world-class care that we got. The infection prevention, everything they do is by international standards and top notch. So, and I'm pretty picky. I have to say, Dr. Ruiz, I'm pretty picky, but it was fantastic. And I was talking to my husband yesterday, and I said, we were there for 28 days and it just flew by, and it went by so fast. And myself personally, it was an easy thing to do. I didn't have any ill effects at all, no nausea. I kind of flew through the program quite easily. But at one point I remember, I guess I was feeling a little anxious about something. So I picked up the phone and I called the doctor, and it was 3 a.m. and they answered right away. And another time I was having a little bit of bone pain, and I called, and there was a nurse at my door in 5 minutes. So even though it is an outpatient, you are very well looked after, and there's no anxiety because you're not in a hospital. So they are with you, even though they're not physically with you, they are available at a minute's notice. So that is very comforting for me. And I can't believe it's been 4 months. I've been home for 4 months, and I loved it down there. Dr. Ruiz, it was awesome. So thank you so much.
Brooke, what was your experience as an inpatient? You did yours inpatient, right? So
Yes, that's correct. Actually, I loved it. The thing is, because my EDSS was between 5 and 6 or 6.5, depending on the day, because I know a lot of people in the beginning, before you're on lockdown, they go out and they explore and they do all the, to the best of their ability. They play tourist. And I was scared to death to play tourist, because I thought to myself, if I trip and fall somewhere before I start my treatment, so I had no problem. It's like being in a cocoon. And, it's not like you're alone, because I had 3 different devices. I had a tablet, I had my phone, I was on my laptop constantly, I was blogging. Plus, the staff is in and out all the time. There's people tooling around all the time. And when I was there were only 2 other patients at that time, 2 other international patients. And then they left and I was there by myself for a while. Well, now, of course, it's not like that. There are full, because they've expanded and there are full-on groups of people. And it becomes like a brother and sisterhood amongst the patients. Like it's not even, like you don't have to worry about getting to and from the hotel and back, you know, your relatives stay there if you brought somebody with you. And I think that's something that should be mentioned as well. In Moscow, they don't require a caregiver, and many people have gone on their own without somebody, whether they were physically capable of doing so, or if they simply just didn't have somebody who could accompany them. And for anybody who's hesitant about doing that, don't be, you'll be taken very well care of, for sure. But no, I loved the experience of being cradled. I mean, I felt cradled, like that's how warm and caring, and yeah,
That's great.
everybody's just one buzz away.
I had a question for both doctors about why you might need to have a top-off dose of chemo after HSCT. Whichever of you would like to speak on that. Dr. Fedorenko?
Okay, thank you very much. Usually we don't recommend top of treatment after transplantation if we use intensive lymphoablative protocol, like in Chicago, cyclophosphamide 200 milligrams without any breaks for 4 days. But we have experience for highly aggressive, very active disease, which is quite more resistant to all standard variants of treatment, and effectiveness of transplantation is usually less than in other patients. For this group of patients, this is about 5% from general patients population. We recommend top of treatment using rituximab or mitoxantrone to increase transplantation result, but this is only for very aggressive multiple sclerosis, not for all people.
Yes.
I was one of those people.
Oh.
I don't know if you knew that, but I was one of those patients. I had an extra year.
The good example of very active, highly aggressive MS and successful treatment. I'm happy.
Yeah. Dr. Ruiz, what is your experience with chemo after HSCT?
We use, like most programs all around the world, cumulative dose of cyclophosphamide of 200 milligrams per kilo in 4 different days. We split the doses. We give 100 milligrams per kilo, and then 7 days after the second block of cyclophosphamide. And by doing this, we have found that the renal toxicity and the bone marrow toxicity is substantially decreased. This is the reason why we split the 2 doses apart the blocks of chemotherapy. We also use, instead of ATG or some other immunosuppressive drugs, rituximab at the end of the transplant once the patient has recovered the white blood cell count. We use a fixed dose of 1,000 milligrams rituximab. This is the way how we calculate and deliver the chemotherapy. In selected cases in which there is renal damage or liver damage or some other condition, we must cut down the doses of cyclophosphamide. But that has happened probably in less than 2 or 3 patients out of the total number of patients that we have grafted up to now.
So I had someone ask how long they should, how long should they stop their drugs before HSCT? So I'm guessing this means like a disease modifying drugs.
We ask the patients to be 3 months without immunosuppressive drugs in order to have the transplant procedure done.
And Dr. Fedorenko, I'll pose the same question to you. How long do you suggest that patients stop their disease modifying drugs before they come for HSCT?
sorry, I left. I'm on duty, but the same rules. We recommend to stop disease-modifying drugs 3 months before treatment.
Jean-Marie, I have a question for you. When did you start growing your hair back?
Well, let me show you. There we go. So my stem cell birthday is June 16th. So that's the day I shaved my head. So it's, but you know, my hair's always grown really slow. So it's coming, you know, it takes time. I would love to see my hairdresser sooner than later, but I don't know when it's going to come back. But you know what? I don't mind, right? It's only hair. Yeah. And I think we can all agree with that. This is nothing. So, and I think there was another question on how I'm feeling now. So I had an EDS of 6 when I went down. I still use my walker for long distances, but I am going to a neurophysiotherapist every 2 weeks. And I'm walking really well with 2 poles instead of my walker. So things are slowly getting better, but I feel great. Like I feel really good. Just, you know, it's patience is a virtue, so they say.
I guess we had a couple of questions. I don't know if Jen had posed these while I was gone, but for the doctors, people have asked about more progressive MS for PPMS and secondary progressive. Do you ever treat patients that have more progressive MS? Dr. Ruiz, if you'd like to speak.
Yes, we have treated all types of patients with multiple sclerosis. The best results have been observed in patients with relapsing remitting multiple sclerosis. The response rate is around 85% in that subset of patients. Response means either stabilization of the disease or improvement as far as the EDSS score is concerned. Now, in the case of progressive multiple sclerosis, the response rate is between 75 and 80%. But again, there is a response in this subset of patients. This is the reason why we accept patients with all type of multiple sclerosis. We always tell them that the chances of having a positive response are better in relapsing remitting multiple sclerosis, but the results in progressive forms are better than any of the currently approved treatments for the disease. So if you accept that the response rate in progressive forms is between 75 and 85%, that's substantially better than 50%, which is the best response that you get with new drugs such as ocrelizumab and so on. So there's no doubt that the transplant is endowed with a better response than any of the drugs used up to now in the disease.
Dr. Fedorenko, is your experience much the same with?
Our experience is the same, and our position is that all patients with clinically active progressive multiple sclerosis have inflammation, not only degeneration. That patients have only degeneration is a mistake. So if patient has inflammation and clinical progression, transplantation can be effective. And we have the same outcome, around 90% for relapsing remitting multiple sclerosis and 75 to 80% for primary and secondary progressive MS, which is much higher than for standard treatment using modern medication like Ocrevus, Stansbury, or Lemtrada. So our position is to provide this treatment for progressive variant because other medication usually fail.
Do either of you have experience with patients needing a second transplant after their initial transplant? Dr. Ruiz?
Yes, we have done 2 patients with 2 transplants with 24 months apart approximately. They relapsed and we did a second transplant, and it's interesting to let you know that the response to the second transplant was better than the one to the first transplant. So the answer is yes, but the chances of needing a second transplant is very low. Since you are accepting that 80% of patients do have a positive response after transplant, then only that 20% of patients could be in the need of a second transplant. What is also interesting is that the usefulness of the immunosuppressive drugs in those patients that do not respond to the transplant is higher after the transplant than before the transplant. So HSCT not only improves your chances of responding only to the transplant, but also improves your chances of responding to other immunosuppressive drugs after the transplant.
And Dr. Fedorenko, what is your experience with this?
Yeah, this is very interesting topic because patients who fail transplantation is quite difficult group. An approach for treatment depends of time of relapse after transplantation, previous transplantation program, the variant of progression or relapse. We have experience of second transplantation. It's about 20 patients, Russian and international, and we developed special transplantation program using another chemotherapy, using combination of chemotherapy with intrathecal administration of chemotherapy for this difficult group of patients. Also, we use monoclonal antibodies for some people who have comorbidities and who relapsed in period less than 1 year after first transplantation. Actually, our position that we should use another protocol of conditioning as a second transplantation than previous treatment. So we have this experience, but second transplantation was safe and with good success rate.
Great.
We are going to publish this data a little bit later.
Great. We are almost out of time. Jen, is there anything else that you think that we should cover before we're done tonight?
Not that I can think of, other than a huge thank you to our doctors and of course our panelists. It's been certainly enlightening hearing from both the patient and physician perspective. And I believe that most everyone's questions have been answered. We certainly encourage folks to join us next month. We're not sure what the topic would be. Dr. Ruiz alluded to the possibility of someday doing a deeper dive, and we would love to invite both Dr. Fedorenko and Dr. Ruiz to consider working with us in the future for one of those more in-depth experience webinars to answer more questions about more specifics for folks other than this brief interview or introduction. It's been amazing to connect with everyone, especially our physicians and our patients and their perspectives about their experiences with HSCT.
And we do encourage everybody to visit hsctwarriors.org to register for Talk to a Warrior. Jen, do you want to talk a little bit about that?
So anyone can, if you have additional questions that come up after this webinar or something you didn't think of today or we didn't have time for, you're welcome to schedule a private call with a whole list of volunteers who are willing to talk one-on-one with you for a good hour and hopefully answer any questions you may have. I actually had one this afternoon with someone who will be in Puebla at the end of October. So please take advantage of that resource. You're welcome to connect with us on our website, hsctwarriors.org, to keep up on all things HSCT, including publications. We try to make those available as well because we know those can be helpful with insurance appeals and helping to convince folks to support the case that HSCT is the path to take. So we are to serve.
Please do, the thing on October 21st will be informed basically by everyone's feedback. So please complete the survey about tonight's webinar. We'd love to hear your thoughts.
Yes, absolutely. And going back to the hair question, I haven't done anything to my hair since I shaved my head on October 17th, 2017. So that's 3 years of hair growth.
It looks amazing.
I could probably use a trim. But it's when it's like you lose your hair and it's an okay thing, and it was a beautiful look. And I'm just curious to see, like, how will it come back?
Well, great. Well, thanks to everyone. Best of luck to everyone on their HSCT journey, and best in health and wellness. And thanks everyone for being here tonight.
Especially the doctors. Thanks so much, Dr. Ruiz and Dr. Fedorenko, for sharing your insights and your support of patients and our perspective. It's just been an honor to connect with you.
Thank you very much. It has been great chatting with all of you. And going back to the hair topic, I could suggest Jean-Marie Morgan, one recipe that my grandmother gave me when I was a little boy. I had a very few hair. And she told me, put some tomato slices in your head. That will work. Okay? So try that, Jean-Marie.
Thank you very much, dear colleagues. Thank you very much, dear friends and MS Warriors. So I wish you to have good luck, to be successful in multiple sclerosis treatment. And thank you very much for sharing your experience and for supporting of this approach. It's really important. So we are ready to join all your activity and to be useful for all our friends, colleagues, and patients.
Thank you so much.
Thank you.
I can't
Thank you so much. It was an honor to have you.
Thank you.
Take care, everyone.
Thank you.
Bye-bye and thank you.
Bye, everyone.
Bye-bye.
Bye.
See you. Thanks.
See you. Bye.